Welcome, everyone. My name is Wargo, and I'm from MD Anderson Cancer Center, and I'm happy to be here today. Today we're going to be talking about unleashing immunotherapy against resectable melanoma, the Surgeon Oncologist Alliance for delivering adjuvant and neoadjuvant therapy. So please continue to eat, enjoy yourselves, and I'll introduce the event tonight. But we're really happy to have you all here. We also have a virtual audience, so welcome to those who are in the virtual audience. So tonight's panelists, we have myself, we have Charlotte Ariyan, who's from Memorial Sloan Kettering Cancer Center, and we have Nikhil Khushalani, who's from Moffitt here, which is great. So really happy to have our experts. Want to thank PeerView for providing this session, and Bristol Myers Squibb and Merck for providing the educational grants for this symposium. And if you haven't already, we have this amazing pre-event survey. So please go ahead, scan the QR code, go ahead and do the pre-event survey. It's a case-based situation which we're going to be going over, so it's high yield, and we're going to try and touch on all these things. Reminder to look out for additional polling during the presentation. You'll see live results up on the screen behind us. And then submit your questions. We'll answer them during the Q&A session. And this year we actually have more time than we have in years past. We have an hour and a half as opposed to an hour prior. In addition to this, for the in-room learners, please use your personal device, scan the QR code on the following slides to respond to the polls and ask the faculty questions. And for the virtual learners, please respond to polls on your screen and enter the questions in the chat window. And so with that, here is the QR code. So again, instruction for in-person learners, just go ahead and scan this QR code with your personal device to either respond to the case scenarios or to ask the faculty your questions, and just go ahead and open the camera app, tap the QR code, focus the camera, and then click the link that appears. And in addition to this, we have a really special thing tonight where we have a prize. So get rewarded for asking and answering questions. So earn chances to win a $50 gift card provided by PeerView by answering these polls and submitting questions to the faculty. The more you participate, the greater your likelihood of winning. So you got to play to win, guys, okay? And scan the QR code to answer the polls, submit questions. If you're a healthcare professional and you see a green winner message on your mobile device, at the end of the session, see a PeerView representative and collect your $50 gift card. And so thanks again to PeerView for providing the gift cards. So you can visit peerview.com/melanoma25. Not only can you view the slides and practice aids now, you can actually download them after the event, and you'll find that there's some incredibly useful information with regard to guidelines, as well as calculators for risk for sentinel lymph node metastases, et cetera, and long-term outcomes. And please do join the conversation on X if you choose to at PeerView. And so now we will launch into the baseline assessment. And to do this, we're going to give you 4 case scenarios to consider. Okay, so get poised with your mobile devices. Those on the virtual learning, please go ahead and get ready, and here we go. And so this is the first of the baseline polls, so please answer the question on your device. So this first case is Emma, who is a 26-year-old female who had a resected stage 2B, BRAF mutated ulcerated 2.4 millimeter melanoma of the upper back. She underwent a sentinel lymph node biopsy, which was negative for evidence of melanoma. And the question is, what next step would you recommend for this patient? So number 1 is no adjuvant therapy. Number 2 is adjuvant interferon. Number 3, adjuvant anti-PD-1 therapy. Number 4, adjuvant BRAF/MEK inhibitor therapy. Or number 5, unsure, I can't decide between adjuvant versus no adjuvant therapy. And so, do we have music back there? And so let's go ahead and look at the results here. And so some of you, about 13%, chose no adjuvant therapy. No one chose adjuvant interferon. Thank you for not choosing that. Adjuvant anti-PD-1, around half of people chose that. And we'll discuss this a little bit more and what may or may not be the right choice for this patient. Adjuvant BRAF MEK 18%, and then unsure. That's going to change by the end of the night. Everyone's going to be sure of what they're doing, and it's going to be great. Okay, so the next case is that of William, who is a 68-year-old male who had resected stage 2B, BRAF mutant disease, had an ulcerated 3.9 millimeter melanoma of the arm, had a negative sentinel lymph node biopsy, and so these are, again, questions about adjuvant for stage 2 disease. And how would you manage treatment for this patient? And so, again, number 1, no adjuvant therapy. Number 2, adjuvant interferon. Number 3, adjuvant anti-PD-1 therapy. Number 4, adjuvant BRAF MEK inhibitor therapy. Or number 5, unsure, I cannot decide between adjuvant versus no adjuvant. Music, please. All right, and so this time around, close to 10% for no adjuvant. Again, lion's share, adjuvant anti-PD-1. More people chose adjuvant BRAF MEK for this particular patient, and still a decent proportion unsure, but we're going to fix that by the end of the night. Okay, and next case scenario. And so this case is going to highlight our next series, and that's for the treatment of stage 3. And this is the case of Rachel, who is a 38-year-old female with a history of stage 3 melanoma, in this case BRAF wild type, who presented with palpable left axillary nodes and no distant metastases. And how would you manage this patient? So number 1, take her to the operating room, perform an axillary lymph node dissection with adjuvant anti-PD-1. Number 2, give neoadjuvant pembrolizumab, followed by surgery and adjuvant anti-PD-1. Number 3, treat with neoadjuvant ipilimumab at 3 mg per kg plus nivolumab at 1 mg per kg, followed by surgery and then adjuvant PD-1 therapy. Or number 4, give neoadjuvant ipi 1 mg per kg and nivo 3 mg per kg, followed by surgery and adjuvant PD-1. Music, please. All right. And so with regard to results, about 10 or 15% of people would take her straight to the OR. We'll talk a little bit about that. Neoadjuvant anti-PD-1 followed by surgery and adjuvant, 23%. And pretty similar, maybe a little bit more IPI 3 Nivo 1 than IPI 1 Nivo 3. And this is a great question because you'll hear a little bit more about this and what might be the right answer here. So, all right, next case. All right, so our next case is that of Hudson, who's a 54-year-old male with stage 3 BRAF mutant melanoma and presented with enlarged or palpable left axillary nodes. And what would you recommend as a next step? So again, number 1, straight to the OR, axillary lymph node dissection with adjuvant PD-1. Number 2, axillary lymph node dissection with adjuvant BRAF MEK. Number 3, neoadjuvant pembro or anti-PD-1 followed by surgery and adjuvant PD-1. Versus neoadjuvant ipi-nivo, followed by surgery and adjuvant PD-1, versus neoadjuvant BRAF MEK, surgery and adjuvant BRAF MEK. Lots of choices. And music, please. All right, and so what did we choose? So fewer people, straight to the OR. This is a big, bulky node. Well chosen there to go to systemic therapy first. Some will treat, though, still, but neoadjuvant ipi-nivo was really kind of the choice of most there, which I think we'll hear is a pretty good choice for this patient, but also some people chose neoadjuvant BRAF MEK. We'll talk a little bit about this. All right. And so with that, we're going to go over just a background and rationale for our discussion today. And note that we're going to have an interactive, this will be a case-based discussion. We'll have some didactic lectures in the middle of this as well. And so we've come a long way with melanoma. The 5-year survival is over 90%, but the stage-specific survival can vary quite a bit. This shows the 5-year survival with all stages, and then melanoma-specific survival according to stage 1 to 3. You can see that stage 1, very good. Stage 2 and stage 3, less so. And there is a lot of heterogeneity when it comes to patients with stage 3 disease. And so if you think about it, stage 3A with minimal disease really have quite good survival, whereas 3B, 3C, 3D, pretty poor survival when you think about it. And this is one of those plots that's can help you really kind of look and see, is this a 3A, B, C, or D? And when how about stage 2? Well, you would think, looking at stage 3, stage 2 would probably have better survival. But when you compare patients with stage 3A disease compared to some of these patients with stage 2, you see that patients with stage 2 can do quite poorly. So, stage 2A is certainly pretty good. 2B, again, not awful, but stage 3C and 3D, here shown for example, but stage 2C, is actually quite challenging. And so, is there a role for adjuvant therapy in the setting of treatment for stage 2 disease? And outcome for stage 2C are generally equivalent to 3B. So that's really an important point to consider. And then the question of adjuvant versus neoadjuvant immunotherapy. And this is a topic that's really we've discussed and has come to the fore. Really, why is, what is the proposed rationale for adjuvant immunotherapy? Well, certainly after a patient has had a definitive resection for either, for stage 3 disease, certainly, or stage 2, the proposed rationale is that there's still residual tumor cells, and that by giving adjuvant immunotherapy, you can actually clean up those tumor cells and really reduce the risk of recurrence. However, there is a proposed rationale for neoadjuvant immunotherapy is that when you actually have a tumor in place and you give checkpoint blockade like anti-PD-1 or anti-CTLA-4 or LAG-3 or the combos thereof, you can actually use that tumor in place to actually immunize against that tumor. And so really the hypothesis is that if you have that tumor in place, you get much more effective treatment with this neoadjuvant immunotherapy. And at the time when you actually resect the disease, you actually have many more and a more diverse T cells that can actually really recognize and eliminate tumor cells. And so that's really the premise for the use of neoadjuvant versus adjuvant. And we'll talk a lot more about this in the upcoming hour, so I won't belabor it now. And so what are our goals for today? First, we want to improve your knowledge of evidence supporting the use of neoadjuvant and adjuvant immunotherapy in resectable melanoma. We aim to equip you with the skills you need to develop collaborative treatment plans that include adjuvant and neoadjuvant use of immunotherapy platforms. And then finally, we want to provide you with guidance on addressing practical considerations with pre- and post-operative immunotherapy. And importantly, we will have a fair amount of time at the end for questions. I think there's a lot of cases that can come up and cases that you've treated yourself, maybe that you'd like to really get some expert opinions on and really get the intel of not only the experts up here on the panel, but also the ones in our midst today. And so with that, I will turn it over. And Charlotte, I believe I will turn this over to talk so that you can talk on modern defenses against recurrence, the adjuvant standards for resectable melanoma.
Okay, great. All right, so as Jen just said, this is going to be very hopefully interactive. We're trying to keep a lot of cases in here to keep everybody interested. So we're going to initially present some additional cases, which I think I'll highlight some points that we'll get some opinions on, and then we're going to go into the data. So hopefully it'll make you realize why you want to listen to the data instead of boring you with the data first.
And these are based on a lot of the cases that we've treated.
Yes, of course. But I think all of us have seen cases like this. So, in the beginning here, we're going to focus a little bit on stage 2B melanoma, and I'm also going to try to integrate some of your questions from here that I'm seeing as I go along. Okay, so this is the first case. Emma, 26-year-old female, otherwise healthy, presents with a melanoma on the back, 2.4 millimeters, ulcerated without a clinical exam that's normal, no enlarged nodes. So she undergoes a wide excision and has a negative sentinel lymph node biopsy. She's officially a stage 2B, but a BRAF V600E mutation is detected. There were some questions about how we think about prognosis in these patients. And, as you heard from Jen, on the whole, stage 2 melanoma, natural history of stage 2 melanoma has about a 30% recurrence rate over 5 years. But This is one of the new, calculators that's from the Melanoma Institute of Australia. It's online, and it has a link to it here. But you can put in people's characteristics, and obtain a risk for her. So you can see that this patient, who's 26 years old, has a 5-year recurrence-free survival of 73% and a 10-year at 60%. Now, I'll caution you, and it's not on this, but the confidence intervals on these are actually a little wide. So I think, when you see someone, right, you're thinking 20, 30% probably, recurrence rate, and this does nudge it one way or another, but it's just blocked off a little bit in this slide. But there are confidence intervals here, and honestly, the confidence intervals are wider at the extremes where you have more difficult making a decision.
Yeah. And Charlotte, how often do you use this in clinic?
I use this a little bit. For me, my gestalt for someone who's got stage 2 or stage 2B or 2C is somewhere around a 20 to 30% risk of recurrence. I don't know if you guys, I quote that to a patient. But this is a more nuanced, and I think it's actually helpful for the patients too, although sometimes they don't get the fact that,
the confidence interval.
The confidence is higher.
It's also, I think, helpful for APPs,
yes,
and some of the supportive team. They, this is an eye-opener for some because they're like, oh my gosh, I had no idea that the risk was this high or this low.
Right.
Well, I think it's also important because this is based on published data. Very large database of over 3,000 patients at MIA, and I think utilizing this and giving some concrete numbers to patients helps. So I tend to utilize this, but I also use the AJCC curves and specifically look at melanoma-specific survival from those curves as well, particularly for someone who's this young.
Right. The only thing I would say is that the AJCC melanoma-specific survival curves give you a better survival, right? So it does point out the fact that recurrences are going to be more, and historically, I guess we've rescued some of these people through non-systemic therapy measures, like surgery, other things. So anyway, but this was one of the questions, and actually the MIA actually has this for sentinel lymph node biopsy. So somebody asked about somebody who has a very early melanoma, how do you estimate their risk of having a positive node or such, and that's on here, and there's other online calculators for that as well. Okay, so here we have young girl, and we're going to just talk about this a little bit, and then Dr. Khushalani here is going to give us some real data, but we're going to just talk about it. So what are the next steps? So first of all, no matter what, APP, physician, we have to set up a contract about whether she's going to be followed with active surveillance, that's what we like to talk about, or whether she's going to receive adjuvant therapy. So maybe I'll start with my medical oncology opinion of would you treat, how would your conversation go about adjuvant therapy in her?
So I think the way I would approach this is fairly pragmatic. She's young, she's 26, apparently in very good health, but certainly has almost a 30% risk of recurrence. So the key question becomes, do we have tools that can, or medications that can reduce that risk? The simple answer is yes, we do. Do those drugs improve overall survival? So far, we don't have that data, and we'll go over that in just a few slides. And then we talk about shared decision in terms of risk-benefit. What is the risk recurrence? What is the toxicity profile of these agents? And can we actually defer treatment? And that's essentially the crux of our decisions, at least on 2Bs. With the 2Cs, we tend to be, I would say, a little more biased in terms of treatment. But with the 2Bs, it's almost a 50-50 split. And then one question that I would like to ask our other panel members is, would you perform systemic staging for this patient, cross-sectional imaging? Because originally, before we had what I would call effective adjuvant therapy, most of these patients were within the domain of surgical oncology or general surgery and would be followed with ultrasonography.
Yes. So, correct. So this is a good question. It gets to one of the things, how are we following people with stage 2 disease? So we know from actually excellent studies of the natural history of stage 2 and stage 3 disease that imaging at the time of diagnosis has a detection rate of less than 5%. You're not going to really find anything in these people. But because there's this consideration of adjuvant systemic therapy, we need to know whether this is being given in an adjuvant or actually you're treating disease. So even though it's so low, I think it's worth doing a baseline scan in these people, and I didn't
agree.
used to do it in those people routinely. And so in our institution, actually, if they choose not to do adjuvant therapy, they are followed entirely by surgical oncology, and we follow them every 6 months with imaging.
I think we do the same.
Yeah.
Yes, same at MD Anderson.
Okay. Dr. Khushalani, is in the pretest, many of you people thought that either one of these people should get BRAF/MEK for adjuvant in stage 2 disease. So do you want to touch on?
Certainly. So the simple answer for that, at least right now, would be no. There is no data to support adjuvant targeted therapy or MAP kinase targeted therapy for stage 2 patients. That data primarily exists for resected stage 3 patients based on the COMBI-AD randomized phase 3 trial. So in this current case, typically the only approved options or FDA regulatory approved options would be adjuvant nivolumab or adjuvant pembrolizumab for 1 year or observation.
Okay, good. So we don't have that option, actually. It's only for stage 3. And what if this patient had come to you, speaking to the surgeon-oncology collaboration, what if the patient had come without a sentinel lymph node? Would you treat, right now we know her sentinel node is negative. Would you treat her adjuvantly without the information of a sentinel lymph node? Is that still important for you for having that discussion?
For me, as a medical oncologist, it's critically important, and I certainly hope, I'm assuming the majority of the audience here is surgical.
Yeah.
I mean, maybe just a show of hands. How many medical oncologists in this audience? All right. I actually strongly advocate for surgery for these patients. I think a lymphoscintigraphy is critically important for several reasons. The presence of the identification of a positive sentinel node has great prognostic value in these patients. It can potentially be therapeutic. Third reason to do it is if they actually have stage 3 disease by a positive sentinel node, they may qualify for additional trials, some of which I'll discuss a little bit later. And certainly if they are stage 3, then the question that Dr. Ariyan asked earlier about adjuvant BRAF/MEK, I think becomes critically important. So I would absolutely not forego a sentinel lymph node biopsy for these patients, even though there is a group right now trying to push that and saying, if you're going to treat these patients with adjuvant immunotherapy, you might as well forego the sentinel lymph node, and I would argue to the contrary.
Yeah, so, and as you said, it opens up another potential, FDA-approved systemic therapy. And getting to this whole idea of risk-benefit ratio, also to know that someone's stage 3 as well, right?
Absolutely.
Yeah. Okay, and now, if Emma had an autoimmune disease, Crohn's disease or other autoimmune disease in stage 2, how does that enter into your risk-benefit discussion?
I think that's really important because, and also it's also important to understand whether this is an active autoimmune disorder, on immunosuppression, on steroids, recent flare, no recent flare. Because if somebody does have active autoimmune disease, I would not recommend treatment with an anti-PD-1 or any other immune checkpoint inhibitor unless I'm actually pushed in a corner to do so. And I can always treat this patient potentially at a later time point if necessary. On the other hand, if this is somebody that maybe a slightly older patient, remote history of Crohn's, that has been quiescent, then I think a risk-benefit discussion is certainly very appropriate. It is, for the most part, safe to treat patients with autoimmune disorders with anti-PD-1 monotherapy. With combination immunotherapy in the metastatic setting, that's becoming a little bit more tricky. There's certainly the risk of exacerbation, but many of those patients can still be salvaged with immunosuppression.
Okay, great.
All right.
We're
Next
going to
case.
move on to this next case, where is an older gentleman, 68-year-old, with a 3.9 millimeter melanoma of the arm, so much more advanced, potentially more disease there, but underwent a wide excision sentinel node that didn't change his staging, which was also negative. So slightly higher risk based upon the primary tumor characteristics. And so if you put his numbers into the MIA calculator for stage 2, you can see that his 5-year recurrence-free survival and 10-year recurrence-free survival is much worse, right? So this is someone who maybe, if we go through these same questions, which we don't have to do anything, every single one of them, but the risk-benefit ratio, right, might favor treatment more in this one,
Correct.
right?
Absolutely.
Yeah.
And I would certainly consider this. In my book, 68 is still young. I mean, we have patients that we are having some of these discussions that are older than that. As long as there's no other major comorbidity, I would absolutely have the discussion of risk-benefit of adjuvant anti-PD-1 for this patient.
Okay, so you're going to go through the absolute risk reduction, things like that with adjuvant therapy, but there's a question on here, and do you worry about giving adjuvant therapy, which may not be as effective as neoadjuvant therapy, as Dr. Wargo is going to talk to you about, and then they're having a kind of a rapid recurrence, 3 months or so after you finish adjuvant, and does that burn a bridge for you for adjuvant therapy?
I think that's a great question, and I think we're still trying to understand that, particularly in terms of trying to define what is primary resistance to anti-PD-1. And right now, for example, the development of disease progression during adjuvant therapy or within 6 months of completion of adjuvant therapy is a different discussion as opposed to somebody who, say, develops a recurrence 18 months after completion of adjuvant therapy. And that also has implications for treatment options in the unresectable or metastatic setting. I think it's also important to take one step back and maybe understand what are the patterns of relapse for these patients. A lot of these patients, negative sentinel nodes, will actually still, about 40% of them will relapse in the nodal basin. And so still, I think from a surgical standpoint, those patients can receive potentially neoadjuvant therapy at the time of relapse, followed by surgical resection, or surgical resection directly as salvage.
Yes. Yeah. There's another good question here is, should we follow the same adjuvant guidelines for someone if it was acral melanoma instead of cutaneous?
I would say the simple answer to that is probably yes. I'd be curious to see what is done at your institutions as well. Acral melanoma, stage for stage, probably does worse. In addition, the other issue becomes is when you look at metastatic data, single-agent anti-PD-1 therapy for acral melanoma patients, the response rate is lower than what you would see with traditional non-acral melanoma, non-mucosal melanoma, because in acral and mucosal, the response rates vary between 20 to 25% for monotherapy, as opposed to about 40% for patients with non-acral, non-mucosal melanoma.
Yeah, I agree.
Yeah, same.
Okay.
Charlotte, while you're advancing, there's a question on here that's right up your alley. Can using immunotherapy improve efficacy of TVEC in non-surgical in-transit disease?
Well, that's a great question. So that's more in the setting of recurrence, and there have been several trials that looked at early trials that looked at combining TVEC with either CTLA-4 or PD-1 that showed great promise and improved response rates. But when this was put into a phase 3 trial of PD-1 versus PD-1 plus TVEC in the upfront setting, so these patients hadn't failed anything else, they had no prior treatment, that trial actually didn't show a benefit of TVEC over PD-1 alone. And so, although if you look carefully, maybe there was a little bit of a signal, but it was actually stopped because there really wasn't a benefit. I would make the argument that that's a high hurdle to get over when you have an untreated population, responsive to PD-1, et cetera, and I think there probably is some synergy. I think we all have some data from that era showing that there is some synergy, but that's not really the place for TVEC, or as the new injectable viruses are coming online from Replimune, et cetera. These are going to be in the PD-1 refractory era patients. That's it. Yeah,
Great. Okay, keep going. Let's go.
Okay, here we go. Steve, who's got otherwise healthy, has a mole of the back, 2.1 Clark-4 ulceration, 1 mitoses, and is he? Okay, let's just say he's a T3. T3B. I think it's supposed to be a little thicker than, but anyway, T3B melanoma. We talked a little bit about this. Should he forego a sentinel node? We're all agreeing to do one here, and it is essential to work with your oncologist, I would say, right, to make sure you're on the same page about that. Right?
Yeah, definitely.
We'll move on. We're getting the thing. This is the sentinel lymph node calculator through the MIA or the Memorial Sloan Kettering, again, based upon these features. Pretty high risk of sentinel node. And here the confidence intervals are shown. You can see it's between 36 and 39%. So it's not terrible there. But as you get earlier, someone asked about a 0.7 or a 0.76. As you get earlier, those confidence intervals can go you know, much, much wider. And that's a little bit unfortunate because that's really the group where you're struggling a little bit.
But I do find these sentinel node risk calculators are very beneficial
Yeah.
in talking with patients about risk.
Right.
You
Right.
know, and for the team, you know, I think
Right.
it's helpful for the APPs and others to really
For
help
sure.
them and help the patients understand their risk of a sentinel node
Yep.
metastasis.
And this is just to point out, across all calculators, with age, there's a lower risk of sentinel node metastasis. We've always known this, but this actually puts it into numbers. So if you put the same numbers, if you take this 25-year-old and make him 75-year-old, you see the risk of a positive sentinel node goes down to 13% or 17% from the MSK calculator. So it really does reduce things, reduce the incidence of you being able to identify a positive node by a lot. With that, I think we're going to move on to the data, which hopefully you'll be interested in now that we've brought up some
All right. So
points.
my task is essentially to go over a little bit of this data. And this is directly paraphrased from the NCCN guidelines. When you look at stage 3 microscopic disease in terms of nodal metastatic disease, i.e. sentinel node positive, stage 3 to stage 3A to 3D, you have several options for these patients. You could use either one of the two approved anti-PD-1 monotherapy agents, nivolumab or pembrolizumab, again for 12 months. Or if they are BRAF V600 mutant, dabrafenib plus trametinib is a very appropriate option as well. And each one of these across various phase 3 trials has roughly been shown to reduce the risk of recurrence in stage 3 patients somewhere between 45 to 50%. Similarly, when you look at stage 3 clinical node positive, so now we're talking about macroscopic disease that's identified either by clinical evaluation or radiographically, again, the same 3 drug categories are very appropriate. And certainly stage 3 in transit, albeit in some of the older studies, I would caution you that in transit disease, in fact, was excluded from some of those trials. But as we all know, they essentially behave in a very similar manner. And I think one of the questions that came up earlier is, should we consider intralesional therapy for some of those patients as well? We certainly do that at Moffitt, but those are usually the patients who relapse with in-transit disease after they've already received prior therapy for stage 3 micrometastatic disease. And I think we all see at least 10 to 15% of our patient populations with that. This is a fairly busy slide, and I certainly won't go through every single bullet point here, but suffice to say, the general surgical paradigms, and this group is certainly are no strangers to this, where there are very specific scenarios where I think you would offer a sentinel lymph node biopsy or lymphoscintigraphy along with your white excision. And certainly there are questions right now on the table in terms of how large or how significant should your margins be. The MELMART study is currently trying to address that as well. And then assuming they're sentinel node positive, they go through the stage 3 with cross-sectional imaging. We typically will perform CNS imaging at baseline for those patients as well. And they're sentinel node negative, the cases that we discussed previously, particularly those that are 2B or 2C. Again, the options would be pembrolizumab or nivolumab as category 1 recommendations. I don't think we're going to discuss much by way of radiation therapy today. And certainly stage 2 patients that are 2A, so the earlier stages, T2B, for example, N0, those patients have a very low risk of recurrence, and observation is very appropriate for those patients. As you will see on the next slide, this is Keynote 716. So this was the first drug that was approved in the adjuvant setting for patients with resected stage 2B and 2C melanoma from an immune checkpoint blockade standpoint. This was Keynote 716. This randomized over 950 patients with pathologically proven sentinel lymph node biopsy negative patients, and they were randomized to receive a year of pembrolizumab versus a year of placebo. And very early in this trial, the curves actually started separating out, and the initial report came out as early as 12 months of follow-up, and the curves have since continued to separate out, and now there's an absolute difference at 36 months of approximately 13% in terms of relapse-free survival benefit. This is now seen both in the subcategory of stage 2Bs as well as stage 2Cs for an overall hazard ratio of 0.62. So essentially a 38% risk reduction, 38% reduction in the risk of recurrence for these patients. A secondary analysis as part of this trial was distant metastases-free survival, which was also superior for patients who received adjuvant pembrolizumab compared to those who did not receive that. So the key question that we often ask as medical oncologists is balancing the toxicity of adjuvant therapy and the number needed to treat. I don't know if you all utilize the number needed to treat at your own institutions, but I recall doing the calculation when Jason Luke first presented this data several years ago, and at that point the number needed to treat was about 14. So for every 14 patients that you treated, one patient would potentially benefit from adjuvant therapy. But as time has gone by and the curves are separating out and the absolute difference seems to be increasing relative to what it was previously, the number needed to treat has certainly improved, and now it's down to 7.8. I still tend to use 5 as my cutoff, but I'd be curious to see what your thoughts are.
I mean, I agree, but I still think what your number needed to treat is for relapse. It's not for survival.
True.
And so I think, you just need to, treat me now versus treat me later, which some people are asking in there, is an important part of this discussion.
Sure.
So whether it's number needed to treat or absolute risk reduction of your total, risk, I think those are really important things. And one thing in stage 2 is that, as you said, we potentially do have a salvage for some of these people, a nodal relapse, other types of things. So this relapse-free survival is very, very important, and so is the distant metastasis-free survival, but some of these are salvageable.
Yeah, definitely. Yeah, I think same, and it's always a very long discussion. It's
Yeah.
like you 40 or 50 minutes for a
Right.
discussion
Yeah.
of adjuvant stage 2, because I think you're going to be, appropriately so, really kind of weighing the risks and benefits, and it's much more equipoise there.
Sure. I think the other thing that's also important in this discussion is toxicity. If you look at pembrolizumab or nivolumab, which is on the next couple of slides, the grade 3 or higher toxicity for adjuvant immunotherapy is about 15%. And that is not a trivial number, particularly when you go back to the case of Emma, who's 26 years old or 26 years young. And to relegate someone like that to a 15 or 17% risk of hypothyroidism requiring chronic endocrine replacement therapy or adrenal insufficiency, which again can be devastating, 2.5% risk of that, certainly increases with nivolumab plus relatlimab. And then, of course, the devastating complications of type 1 diabetes. At Moffitt, we see about 2,000 new melanomas to the Institute per year. And so we see a lot of these complications just by virtue of the numbers of patients that we treat. And for every diabetic, I can literally count on our fingers once they've gone on to insulin pumps and how we have unfortunately adversely impacted their lives. So I think that risk-benefit balance is critically important. This forest plot essentially shows you the benefit of pembrolizumab essentially across a lot of the parameters and demographics that were studied here, across age, T-stage, sex, and virtually everything else as well. And similarly, Checkmate 76K was the adjuvant nivolumab trial that randomized around 750 patients, but this was slightly different. This was a 2:1 randomization in favor of nivolumab, virtually the identical patient population, stage 2B, 2C, resected central lymph node negative, and almost a mirror image of what we saw with Keynote 716 in terms of recurrence-free, relapse-free survival for these patients as well. And this allowed the FDA to approve nivolumab for this specific indication as well. And here is the forest plot for Checkmate 76K, again, very similar with virtually everything favoring the adjuvant nivolumab use. So the question then also comes down is, can we actually identify higher risk patients? So this is a very interesting trial, the Nivo-MELA study, and this is based on gene expression profiling from the primary tumor that has previously been validated in a couple of European studies, an 8-gene Melogenix GEP profile that identifies patients or dichotomizes them to high risk versus low risk. And about 40% of patients will be low risk, and their melanoma-specific survival at 5 and 10 years is about 92%. So those patients can safely go on to observation, as in the light blue arm here. But the high-risk patients are then randomized to receiving nivolumab for 1 year or observation, and really trying to say, can we utilize molecular characteristics within the tumor to actually risk stratify and hopefully benefit those patients? Thoughts on this trial? Data will tell us.
Data will tell.
Yeah.
Is there a role for combination immunotherapy? As medical oncologists, we keep saying, let's add drugs to this armamentarium. We can deal with the toxicity, but what can we do with improved efficacy? And unfortunately, to date, there has not been a single trial in the phase 3 setting that has demonstrated superiority of combination immunotherapy in the adjuvant setting. This was the most recent sort of disappointment that we had. This was Relativity 098. Patients with stage 3 resected or stage 4 resected patients, over 1,000 patients randomized to nivolumab as standard of care for 1 year versus nivolumab plus relatlimab, which, as everyone knows, is approved in the advanced unresectable setting. And based on a public release analysis, the primary endpoint of relapse-free survival, unfortunately, was not met with the combination arm. We have not seen the data yet, and we anticipate this will come up at one of the upcoming congresses, whether it's ASCO, ESMO, SMR, or something else. I think we will find out in due course of time. There is another ongoing study that has just completed accrual, or at least just completed screening as of last week. I think they'll finalize their accrual within the next 3 to 5 weeks. And this was utilizing the Regeneron combination of anti-PD-1, anti-LAG-3, which is cemiplimab plus fianlimab, 2 separate doses of fianlimab, versus pembrolizumab plus placebo, and that is the standard of care arm in this particular registrational trial. And again, 1,500 patients. The difference here being that there's high-risk stage 2 included in this patient population and appropriately stratified as such as well. Primary endpoint, again, being relapse-free survival for these patients. I anticipate results probably over the next 18 to 24 months with this combination. And then finally, I think what generated a lot of interest and a lot of excitement was the mRNA study. And this was the mRNA V940, which is, as many of you know, an investigational mRNA-based personalized cancer vaccine that is a synthetic mRNA that codes for up to 34 neoantigens. So very simply, on the left-hand side, you'll see the cartoon where the injection of the mRNA based on, from the tumor characteristics itself, is taken up by antigen-presenting cells and other cells, incorporated in the ribosome. Protein chain is manufactured, which in turn undergoes degradation within the proteasome to construct peptides, which are then sort of cycled through the endoplasmic reticulum and the Golgi apparatus, and then eventually presented through MHC molecules to the T cells. And this was, the late, great Jeffrey Weber's sort of labor of love. And in this vaccine study, which randomized patients to receiving their personalized vaccine plus pembrolizumab versus pembrolizumab alone, this was the randomized phase 2 trial, Keynote 942, essentially demonstrated a 20% improvement in relapse-free survival at 30 months. This was data that was updated by Dr. Weber last year at ASCO and then subsequently published in the Lancet. So this really exciting sort of personalized melanoma vaccine in conjunction with immune checkpoint blockade has led to Interpath 001, which is essentially looking at this in the phase 3 setting, randomizing 2:1 to the combination arm, including the vaccine versus pembrolizumab plus placebo. And this trial has already completed accrual. It's probably accrued one of the fastest accruing adjuvant trials in the history of melanoma, and results from this trial are currently awaited. So essentially, going back to the cases that we had Emma, we had William, and we had Steve. And certainly I'd be curious to see what you in the audience thought about this. But clearly Emma, based on the MIA calculator, does have a good chance for prolonged relapse-free survival. Adjuvant therapy is certainly a consideration, but as I mentioned earlier, risk discussion, potential long-term safety considerations. Maybe Emma would like to have children, or whether or not she's completed childbearing, depending on her family situation. Those are critically important questions that we have to ask. William, based on the MIA calculator, higher chance for recurrence, and certainly adjuvant anti-PD-1 therapy would be very reasonable, though observation is not an unreasonable choice for William as well. And then finally, I think in Steve's case, there was no argument, I think, performing a sentinel lymph node biopsy for prognostication, therapeutic efficacy, and really making a better decision for his disease for further decision making. So I think multidisciplinary dialogue is critical for these patients, medical oncology, surgical oncology, selected cases, radiation oncology as well. Back to you, Jen.
All right, thank you very much. Okay, so we're going to do our follow-up poll. So going back to Emma, 26-year-old female, resected stage 2B BRAF mutant, ulcerated 2.4 millimeter melanoma of the upper back with a negative sentinel lymph node biopsy. What's your next step? Play the music. There was some learning done. There you go. So no adjuvant therapy, about close to 40% adjuvant, anti-PD-1, around 50%. So I think, strong work, everyone. I think, very, very good choices. Definitely this is like an hour-long conversation in the room with the patient, but I think, I think there was...
It is. And so one person's question is saying, what's the harm in waiting for recurrence and initiating IO ahead of, with the recurrence? And I think we all agree that that is a safe option, right?
It is a very safe option.
Yeah.
I think the discussion that I do have with patients is, if you go back and again look at patterns of relapse, the majority of these patients, when they relapse, do have distant metastases. And once these patients develop metastases to the liver, metastases to the brain, those can be devastating, and it's much harder for us as medical oncologists to treat those patients. So it's sort of almost goes back to the old paradigm, strike when the iron is hot. But at the same time, I think as these are tough decisions. So the person who chose persons who chose unsure, I'm actually with them. I think that's okay. This is a tough decision.
It is.
And, I think the benefit really needs to still be borne out. And, we can't make decisions for patients, but rather we make decisions with them.
Yes.
And part of the reason why it's unsure is we just don't have survival benefit, right? That's the thing that would make us more sure, right?
I agree.
Survival data.
I agree.
Yeah.
All right, so we'll move on to our next patient, William, the 68-year-old male with resected stage 2B BRAF mutant disease, 3.9 millimeter melanoma of the arm, negative sentinel lymph node. How would you treat William? Higher risk patient.
Look at that.
Yeah, look at that. Yeah, all right.
All right, just to add in another question from the group here, would a high-risk score in DecisionDx influence your decision whether to recommend adjuvant therapy?
My simple answer right now would be no. We don't use that in our clinical practice. We have not really found it very useful. It has not really supplanted all of the other pathologic characteristics that we can derive, as well as demographic characteristics.
Yeah, I agree. For us too.
Yeah, same. All right, on to the next patient. On to neoadjuvant immunotherapy, and that's my cue. And so what I'll talk about now is deploying neoadjuvant immunotherapy with new benchmarks for enhanced outcomes. And so, again, to launch this off, we'll talk about a couple cases. So our first patient is Rachel, and this is a 38-year-old female, no known prior history of a melanoma, but presented with enlarged lymph nodes on screening mammogram. She underwent a biopsy that showed melanoma that had a BRAF mutation, and a PET CT showed activity in the left axillary nodes with no evidence of distant metastases. I forgot I'm driving. Okay, so the workshop discussion here, kind of the next steps for Rachel. So one question is immediate axillary lymph node dissection followed by PD-1 adjuvant therapy the best course of action? And so this is kind of going to that neoadjuvant, adjuvant question. And, what do you think, Charlotte? How would you treat this patient?
Yes, so this gets to some other questions in here. This is resectable disease, low volume disease, but a young and healthy patient. And we now have data, as you guys know, and we'll see more, that neoadjuvant provides a better long-term outcome. Again, it's event-free survival, not overall survival, but it's in a prospective randomized fashion. I would push her hard to have neoadjuvant therapy, and then we could discuss from there based upon. But
I would agree completely.
Yeah.
This would be a
Go for
very
the home
appropriate candidate for neoadjuvant therapy.
Yeah. And then Charlotte,
Yeah.
single agent, dual checkpoint, BRAF MEK, What do you say?
Well, we're very biased where I am to go for dual agent, and we are more comfortable de-escalating therapy based upon good path response after that. So for me, you get a personalized response after 2 doses. You also have the potential to not be treated for a year. So that's it. But not everyone is backing off on that. So, I don't know.
I agree.
Yeah.
I mean, that's our bias as well, dual checkpoint blockade unless we have a clinical trial.
Yeah.
Particularly for the fact that you can get away with 2 doses and then potentially pursue risk-adaptive post-operative therapy based on final pathology, or forego post-operative therapy altogether if there's a great pathologic response.
Can I ask one question in here? When
Please.
this thing, all right, so there is a question here. Are you routinely offering egg harvesting or sperm banking in patients who are young and decide to proceed with neoadjuvant or adjuvant?
We are not. I mean, we have an AYA group, so adolescent and young adult group, and we would certainly incorporate their input as well. We are telling we don't do that ourselves. Obviously, we have to send them to the appropriate folks within Tampa to get that done. We will certainly discuss that with them, but what the advice that I give these patients is that after completion of nivolumab or pembrolizumab, usually we wait for at least 7 months before they can consider starting their families or going back to something like that. And I think most patients will tend to follow that. I think it's just practically a little bit harder to get them to the appropriate fertility specialist, gynecologist, to actually get everything done by the time I can start my neoadjuvant therapy as quickly as next week.
And then for dual checkpoint blockade, Ipi-Nivo, what dose, how many doses of each? What do you say, Charlotte?
Well, we give this flip dose routine, which you're going to get into a little bit, and 2 doses, although we have an ongoing trial right now at Memorial giving a single dose of combination. So that's going to be presented at ASCO.
Okay.
Yes.
Yeah.
So Ipi-1, Nivo 3.
Just a single
is the
dose.
flip dose.
Yeah.
And then
Right.
Nikhil?
We do the same. We did the 1 and 3, so Ipi-1, Nivo 3, as we call flip dose or flippy. If you look at the Nadina trial, they use fixed doses. It's far easier to do that, I will say. So we've actually modified our electronic medical record orders to actually say 80 milligrams of ipilimumab, 240 milligrams of nivolumab for 2 cycles. And that way nobody makes any math mistakes with that.
Yeah, and we do the same, either 2 doses of flippy, if you will, or sometimes we'll do Ipi-Nivo, Ipi-1, Nivo 3, and then followed by 2 doses of just nivolumab monotherapy. All right. Okay, so our next patient is Hudson, is a patient with stage 3 melanoma. So this is a 54-year-old male who has a history of melanoma, actually went to the gym and reported feeling a knot in his axilla, subsequently had a biopsy confirmed BRAF mutant melanoma, and you can see this very large axillary mass here, and CT showed that enlarged left axillary nodes, no evidence of distant metastases. And so, again, going back to the discussion, show of hands, anyone take him straight to the OR? Nah, I think we'd favor treatment with neoadjuvant. And then, if so, again, what do you think, Charlotte? What would you treat him with? Still dual?
Yeah, for sure, because he's got a larger tumor burden, and you want to get a response.
Right. Nikhil, same?
For me, the answer right now is still dual checkpoint blockade. I would not discount neoadjuvant BRAF/MEK. I mean, I have certain biases from that standpoint because I think the data for neoadjuvant BRAF/MEK has all been conducted with very finite durations of treatment, usually anywhere between 8 to 12 weeks. At our institution, we've actually believed strongly that a longer duration of neoadjuvant BRAF/MEK is actually very good. So we have a trial that is almost ready to finish where we've done 6 months of neoadjuvant encorafenib binimetinib, followed by surgery, followed by risk-adaptive postoperative therapy, whether they switch over to nivolumab or observation or continuation of BRAF/MEK. So I'm very curious to see what that data shows us. But if you look at the INMC pool data and look at all patients across multiple trials treated with BRAF/MEK neoadjuvant or immune checkpoint blockade neoadjuvant, even those patients who had a pathologic complete response to BRAF/MEK, unfortunately, do have a higher incidence of relapse relative to those who got neoadjuvant immune checkpoint blockade. So right now, based on the existing data, I would say dual checkpoint blockade.
Okay. And I'll digress for a minute. Do you know one of the single most, strongest predictive factors of response to neoadjuvant BRAF MEK inhibitors? Charlotte.
I'm sorry.
Do you know, and this is guess
No.
what I'm thinking here,
Yeah.
but we actually ran a study where we looked at patients treated with neoadjuvant BRAF MEK inhibitors. And what we found is that females were most likely to benefit. And it's androgen receptor signaling actually can promote resistance to BRAF MEK, and if you give them enzalutamide or AR blockade, you can actually improve response. But people don't love the AR
I
blockade.
actually
So really
did
interesting.
not remember that.
Yeah, yeah. So
Thank
looked in, I think, Nature.
I thought that was going to be a trick question.
Yeah.
What's the single most
Yes.
important predictive
Yes,
factor
yes.
for BRAF MEK? I was going to
Yes.
say having a BRAF mutation.
Yeah,
Yes,
see,
that's
that's
what I
right.
was
But
thinking,
then
my God.
female sex,
Yes.
is
Okay.
actually one of the
that's
most
great.
important. So it's kind of cool stuff, right? You know,
Yeah.
so it actually does matter. Okay, so let's go back to the now, thankfully neoadjuvant therapy is actually now supported by practice guidelines. My mic is a little funny. The NCCN now recommends neoadjuvant options when appropriate. If you guys can fix my mic. Okay, so for stage 3 clinically positive nodes, for stage 3 clinical satellites or in transits, and for nodal recurrence, okay? And preferred regimens, either pembrolizumab, nivo-ipi, or other recommended regimens like nivo-relatlimab as well, or nivo-lag-3, okay? And so we'll talk a little bit about the SWOG 1801 study. We'll also talk about the NADINA study, OPACINE-NEO, and we may touch on Prado, but I know there was a question about it as well. And useful in certain circumstances, again, I'm 1,000% with you. Neoadjuvant dabrafenib, trametinib, or some of these, the next generation BRAF MEK inhibitors can be quite useful, especially in bulky disease, high LDH, patients who you really need a rapid response, who may or may not respond, to, and also have contraindications for
Right.
treatment with neoadjuvant immunotherapy. I think BRAF MEK is a very useful tool. And again, we'll kind of call out to the OPACINE-NEO study where flip dose, or this Flippy, I like the Flippy analogy, is maximized efficacy and limited toxicity, and we'll show you that a little bit. So 2 doses of the IPI-1, Nivo-3, and that's kind of what is traditionally used. And so guidelines on using this dual checkpoint blockade, adjusting the dose. So, we had actually run a study early on looking at IPI-3, Nivo-1. We found, effective, right? We nearly doubled the path CR and tripled the response rate, but it came at a cost. It was 73%, grade 3 or above adverse events versus 8% with the neoadjuvant anti-PD-1. And similar, so, when Christian Blank and others ran this OPACINE-NEO study, they found with this, with the IPI-3 Nivo-1, the grade 3-4 toxicity was 40% with 80% pathologic response, whereas if you do IPI-1 Nivo-3, you get 20% grade 3 or above with pathologic response, very similar, 77%, okay? So it's a pretty clear and resounding message that the safety and efficacy of flip dose confirmed in OPACINE-NEO trial and was actually used in the recently published NADINA trial in the New England Journal. All right. So now we're going to actually go to another case. So this is Audrey.
Can I just add one
sure,
thing
please.
before we move on there?
Yes.
So we didn't, there's a question in here about, should we still be thinking about neoadjuvant if this was an acral melanoma with metastasis to the groin, for example, low TMB, does this neoadjuvant protocol information
Translate.
And so I just wanted to highlight, acral patients were included in the NADINA trial and the SWOG trial.
Yeah.
So, right, you would still...
Correct. I would still do the same thing, particularly, in fact, those would be absolutely the ones that I would use combination immunotherapy.
Right.
Yeah.
Right.
All right, so getting back to Audrey here, so this is a 24-year-old female with a history of a T2B ulcerated 2.8 millimeter melanoma of her upper back, underwent wide local excision and sentinel node biopsy. The sentinel node was positive. She had a BRAF mutation. She actually received a year of adjuvant anti-PD-1 therapy, but then 1 year after completing therapy, she actually presented with a mass midway between her surgical scar and her axilla. And so the discussion point. So what is the next step for management. Show of hands. So this patient had a history of a melanoma, ulcerated melanoma on her arm, or on the upper back rather, had a positive sentinel node in the axilla, shows up with her mass midway. Who would excise it? Anyone? Good. Okay. So, or would you do a FNA? What do you think, Charlotte? Yeah, thank you. Yes. So do an FNA. Okay. And what would be your next course of action if this is proven to be melanoma? Nikhil?
There are two ways that I would approach this. One is surgical resection with negative margins, and this was, if I recall correctly, a BRAF mutant patient. So with BRAF mutant disease, you could resect and then potentially offer this individual a year of dabrafenib trametinib. I think that's very reasonable to pursue. An alternate approach would be, given that this is 1 year since completion of prior anti-PD-1 therapy, it's very reasonable to now use neoadjuvant ipi-nivo in this setting, a la, again, Nadina, though Nadina did not allow prior immune checkpoint blockade. But with a year of interval in between, I would anticipate we would still see robust responses in those patients as well. And so giving 2 doses of flip dose ipi-nivo followed by surgical resection would be very appropriate. I would even throw out a third option there is, if this is easily palpable, can we actually consider intralesional therapy? This may be one of those cases that TVEC may be very reasonable to consider, but for a 24-year-old to keep coming back every 2 weeks may be difficult.
Yeah.
Charlotte, how would this patient be treated at Memorial Sloan Kettering Cancer Center?
Well, I agree. I mean, there's lots of options for them. And I think one of the things that we struggle with that this question's trying to get to is, when is a person really resistant to PD-1, right? This person, got adjuvant PD-1, yet they still had a recurrence. Is it different that they have a recurrence 3 months after completing PD-1 or a year after? I think our thought is, yes, they are different people. And so we're still quite, enthusiastic to still use, immunotherapy, as you talked about. But I agree with you, with a single lesion, resectable, and an adjuvant BRAF MEK is also an option. I'm less enthusiastic about injectable therapies in this young patient. I think she just, won't tolerate it. But I think if this patient was 94, we would either take it out or do TVEC, and not do systemic.
Right.
Sure.
So, yeah.
Fair enough. Okay. All right. So now we'll just go over some of the evidence for clinical decision-making with neoadjuvant immunotherapy. And so Nikhil had alluded to this earlier. This is a pooled analysis from the International Neoadjuvant Melanoma Consortia, really comparing the use of neoadjuvant immunotherapy with the use of neoadjuvant targeted therapy, and really looking at outcomes in those patients. And what you can see is that if patients are treated with neoadjuvant immunotherapy, if they have a pathologic complete response, near path CR, or a partial response, they actually have incredibly good survival, relapse-free survival, compared to those who have no response, who actually have a poor survival. And can you tell who those patients are? You actually can. Christian Blank actually showed that TMB and interferon signatures could actually predict those patients in a pretreatment biopsy, so really important. Now contrast that with the use of neoadjuvant targeted therapy, and you see that if patients have a pathologic complete response, they do well, but a lot of those patients relapse, and often in the brain. But if they don't have a pathologic complete response, anything less than a complete response, they really do quite poorly. And so this really is proof of principle that, if patients can tolerate it, using neoadjuvant immunotherapy is really preferred. And then how about the SWOG S1801 study? So this was a really important study done, published in the New England Journal by Sapna Patel and others, showed neoadjuvant and adjuvant pembrolizumab prolongs event-free survival versus adjuvant pembrolizumab alone. And basically what they did is they took patients with melanoma and actually treated them either, for the same amount of time, 12 months, either getting first neoadjuvant anti-PD-1 followed by surgery versus adjuvant, or did a resection and then just got 12 months of adjuvant. And what they found when they did this is they found that patients who were treated with neoadjuvant and adjuvant had much better event-free survival rates. And so, again, proof of principle, using neoadjuvant is really the right thing to do, and benefit of neoadjuvant therapy was apparent across all subgroups. And then really just follow-up data, high rates of pathologic complete response were reported, and the relapse-free survival by pathologic response. Again, you can see path CR, near CR, and partial responses, very good. Non-responders, not as good, again, but can we actually identify those patients potentially? But a caution is there remains a need for standardized definitions and assessment of pathologic complete responses. We really need to work with our pathologists, and there are white papers out on this to actually educate the pathologists how to look for a pathologic complete response. Nonetheless, there are, I think, opportunities to really streamline this and to democratize this, and the International Neoadjuvant Melanoma Consortium is trying to do that. And that's really to inform neoadjuvant treatment choice and selection of single agent versus combo. And then NADINA, this was a study that tested neoadjuvant ipi-nivo, again alluded to by our esteemed speakers here, with standard adjuvant nivolumab and macroscopic stage 3 melanoma. And so this really was, this phase 3 trial looked at 2 courses of ipi-nivo. Again, this dose of 80 of the ipi and 240 of nivo every 3 weeks for 2 doses, did a therapeutic lymph node dissection, and then looked at major pathologic response in patients who got a major pathologic response, meaning less than 10% of viable tumor. They really were just observed. Whereas if patients had residual disease at least over 10% vital tumor cells, they were treated in the adjuvant setting with nivolumab at 480 mg every 4 weeks, and 46 weeks of DAD-TRAM, if relevant. And this was compared to the patients who underwent therapeutic lymph node dissection and then had adjuvant anti-PD-1. And this really defined this. And so in NADINA, neoadjuvant dual checkpoint blockade was associated with significantly improved event-free survival versus adjuvant. Again, you see a theme developing here. So again, the neoadjuvant versus adjuvant, just like in the SWOG 1801. The SWOG 1801 was PD-1 monotherapy. The responses are better here. So primary endpoint was met with an improvement in event-free survival consistent with prior published data, and the neoadjuvant ipi-nivo also improved the distant metastasis-free survival compared with standard of care adjuvant PD-1. Yes.
Can we stop for a second?
Please, yeah.
Yeah, is that okay?
Yes.
Yeah. Okay, so a couple questions here. What if this is great, right? So I think one thing to highlight is this trial is resectable disease, and there's a lot of questions about unresectable disease. That's a different animal, right?
Correct.
And so these patients have resectable disease. You're going to operate on them at a defined endpoint after 2 doses. If you see a flare, the lymph nodes are getting bigger, would you not take them to surgery, Dr. Wargo?
Well, you can often see a flare with ipi-nivo where, we will often go to a biopsy. Say they have cervical lymph nodes, they have axillary nodal disease, they get ipi-nivo, and all of a sudden, they have hot, enlarged nodes in their neck. We'll actually do a biopsy and see, is this just reactive, and then just continue on.
And what if the axillary nodes were just getting bigger?
If they're resectable, we would still resect it.
Yeah, we would too. I would say it doesn't matter. They're progressing or they're not progressing. We're going to go to surgery for regional control. Hopefully, it's pseudo-progression, which I think really happens 10% of the time or so.
It does.
But so you could have a flare that's not real, but otherwise. And so people are saying, what percentage of the time does unresectable become resectable? I think we have to extrapolate from the stage 4 data for that. Yeah. These are not these patients, right?
Mm-hmm. I think we've all seen those patients where, borderline resectable, someone with, very close to the axillary artery, potentially encompassing the axillary vein, which certainly can be sacrificed. Of course, you tell me, all of the surgeons. Yeah. But, we've given them definitive therapy, as we've called it. Yeah. But if they do become resectable, we absolutely will pursue surgical resection for those patients.
Right.
It's a really nice indication if they have a BRAF mutation for BRAF MEK inhibitors too.
Right. So that was a question in here. If they progress after 2 doses of ipi-nivo, do you go to surgery or do you go to BRAF MEK?
I think that's a great question. It really depends. If those patients are still resectable and with minimal morbidity, I would directly move forward with surgery, and then based on the pathologic response, potentially offer them post-operative BRAF MEK inhibitor therapy if they still have viable disease. Yeah. Dr. Sondak will routinely quote examples that he and I share where he's taken patients to the operating room, looked at it grossly and said, there is no way that this is response. It all looks like viable disease. But when Dr. Messina, our pathologist, calls us back and says, we don't find any evidence of disease here.
Yeah. But I agree 100%, but I would say the opposite scenario is also really important as surgeons. The patient's progressing on immune therapy. You know they have a BRAF-MEK mutation, but surgery still plays a role in regional control.
Absolutely.
So take it out and then let our medical oncologists give it adjuvant, right?
Sure,
Because you could move right to BRAF-MEK, but I wouldn't do that unless you really thought that it was unresectable. I would still not lose that window, right?
Right.
Because it's a 50% response rate, but it's a 50% non-response.
Right, and maybe we can touch on, because I know a lot of people were soured with BRAF-MEK in the stage 4 setting, advanced disease, but in the adjuvant setting, Nikhil, you can enlighten us, but I mean, it's pretty effective
Oh,
in
it's
the
very
adjuvant setting.
effective. I mean, you look at Combi-AD, and in fact, if I have all things considered equal, if I have a patient that's eligible in the stage 3 setting for adjuvant BRAF-MEK or adjuvant anti-PD-1, I tend to steer them towards adjuvant BRAF-MEK for a variety of reasons, but a lot of it is the efficacy is very similar. Toxicities tend to be short-lived and most importantly reversible. So you stop the drugs, toxicities go away as opposed to some of the chronic toxicities with immunotherapy. And God forbid if they relapse, I can still salvage them with combination immunotherapy potentially at a later time point.
Okay.
Shall we move on?
Yes.
Okay. All right, and so this is getting into patients receiving neoadjuvant therapy who achieved a major pathologic response, or MPR, or a radiological response at favorable relapse-free survival and distant metastasis-free survival. Again, kind of just driving home that same point. So non-responders, and we see these curves over and over with the different regimens. Now, how about neoadjuvant Nivo-Rela, or PD-1/LAG-3 combination? And this was a study that we actually did with Memorial Sloan Kettering, and actually showed that this can actually be quite effective with a high rate of pathologic complete responses. 57% path CR rate when we ran this study together. And so you can see that the relapse-free survival when they've had a major pathologic response was quite good. Versus if not, and again, the probability of survival. And how often do you use this, Charlotte and Nikhil, the Nivo-Rela in the neoadjuvant setting? What do you think? Nikhil, we'll go to you. Yeah.
We've used it before. We actually presented some of our data at ESMO last year, and I must admit I was a little bit disappointed with our own internal data. It was not as robust as the MD Anderson data. We haven't gone back and tried to compare what was different between the two. So right now, my personal preference is still to use Ipi/Nivo at the flip dose, but if I feel that there's a patient who may not tolerate the toxicity of Ipi/Nivo and I still want to use combination, I absolutely will use Nivo-Rela. That I will tell you from a regulatory standpoint, certainly harder to get insurance approval for Nivo-Rela in this particular setting.
Yeah, I think there's overall more data for Ipi/Nivo. But this, again, the benefit of this is the less toxicity. So same with us.
Yeah, and I think we share the same. We had this initial data which was like, wow, this is the best, right? But then, as time has gone on, the response rates are not quite as good, and I think we still reach for Ipi/Nivo flip dose in patients who can tolerate it. And then immune-related adverse events are important, right, and very relevant to the surgeon. And if you look, this is a paper that Beth Helmink and others published on toxicity of immune checkpoint inhibitors, considerations for the surgeon, published in the Annals of Surgical Oncology. I think it was 2021, if I can read. But basically, you can see skin rashes happen early on, along with GI and colitis. And then you have later toxicities, pulmonary, GI, hepatitis, endocrine. A lot of times you'll see this, patients are treated with neoadjuvant immunotherapy. They go to the OR. All of a sudden they're punky, and what's going on? They're not getting out of bed, and lo and behold, they have adrenal insufficiency. So it's really important to keep an eye out for that.
Yeah, and that's right. If you're going to get 2 doses of Ipi/Nivo, which is 3 weeks apart, and you go to surgery, it's right in your post-op period where you have to think about that with some of your patients.
So, and we actually saw a higher incidence with Nivo-Rela in that setting. When you look at the metastatic data, Nivo-Rela has a higher incidence of adrenal insufficiency. And we saw exactly what you're noting. So now our protocols are 2 doses, and prior to surgery, when they come back to see the medical oncologist and surgeon at the same time, I always make sure they get an ACTH and cortisol level just for that risk of subclinical adrenal insufficiency that then gets unmasked by the stress of surgery.
Exactly, we do the same. I think it's really important when you're getting these patients back after getting treated with neoadjuvant immunotherapy, check an ACTH, and cortisol, because you don't want to wind up in the OR with a patient with this issue. So, all right, and so how about after immunotherapy treatment? What are the implications for surgeons? And so, one consideration too is this autologous tumor-infiltrating lymphocyte therapy. Lifileucel is now an option where you can actually resect a tumor and actually procure these tumors that can actually be used to then generate, a product, a cell therapy for that individual patient. They do have to undergo non-myeloablative lymphodepletive chemotherapy. They then get this TIL infusion and get interleukin-2 up to 6 doses, and then after that can be discharged. I will tell you, it does take time to make this TIL product, and there are a lot of nuances with regard to the tissue procurement. But this is another reason, and I think Charlotte brought this up earlier, is, a patient who comes in with an in-transit MET, before you reach for your scalpel, think about, do an FNA, treat them if necessary, but, could this be a patient who's a candidate for TIL? Any other thoughts on that, Nikhil?
No, I agree completely. Again, right now, till at least in terms of the placement, and the way I try to sort of look at this is, how long is my runway to land this plane, and how many options can I utilize, and when should I utilize them? But for TIL, I think it becomes critically important to think about that early, because as Dr. Wargo mentioned, it takes time for these patients to move from us to the surgeon to actually getting to the inpatient setting, getting the approval for it. All of that, even though it says 3 weeks for the actual generation of product, I can tell you practically it takes a little longer.
Charlotte, any other thoughts on TIL?
Yeah, no, I think as a surgeon, I think you need to think about it ahead of time. Someone comes back with recurrence, and maybe they're going to go on systemic therapy, maybe they're going to, have these things. And so I say to the patient, okay, we're talking about someone who's already failed PD-1, but if they haven't yet, I think, okay, well, this site might be a good site for TIL. We're going to protect this site for our TIL harvest and lymph node, et cetera. Again, this is with more widespread metastatic disease. I think it's important to be thinking about this and protect those sites, don't radiate it or something else, first, without a discussion of should this be a site that we shouldn't radiate and we should think about TIL.
Yeah, don't burn a bridge.
Don't burn a bridge.
Yeah, exactly. All right, and then randomized controlled trial of checkpoint blockade versus TIL. So there were a total of 168 patients. 86% had disease refractory to anti-PD-1, but not all were assigned to receive TIL or ipilimumab. So 89% had PD-1, 20% adjuvant PD-1, 62% were first line, and 11% no prior treatment. And so you can see, here the randomization and here's the TIL improved progression-free survival compared with IPI in the post-PD-1 setting. Technical considerations, harvest tumor, prioritize most easily accessible. Again, getting back to that point, someone comes in and they have multiple sites of disease. They're saying, I have this lump on my arm, and they have lung mets. Don't just pluck off the thing in their arm just because it's easy. It could actually be a great site for TIL. Low morbidity, aim for sites that have low morbidity, expedite wound healing. They're going to have to go on to non-myeloablative chemo regimen. And then, so you really have to consider that. And then the tumors have to be handled sterilely throughout the process. It's a cell therapy, not a specimen, and subject to rules of cell therapies and chain of command as well as CLIA. So really getting back to this recap on the choices with neoadjuvant immunotherapy. So Rachel is our 38-year-old with stage 3 melanoma, BRAF wild type, left axillary nodes, no distant metastases. Really good candidate for neoadjuvant therapy. Given her age and presentation, could be a good candidate for this flip dose dual checkpoint blockade, the Flippy or Ipi-Nivo, Ipi-1, Nivo-3, a la Nadina with 2 doses. Potential for response-guided adjuvant therapy. So do you have to, there's a good one, do you have to, Nikhil, do you treat everyone who's gotten Ipi-Nivo with adjuvant PD-1?
No. So those patients who have a pathologic complete response or major response, so less than 10% viable tumor, we will just observe. Yeah. If they have a path partial response, we will certainly consider further post-operative therapy. And I tend to see some of those who start off with very bulky lymph nodes. They still have some disease. They clearly have treatment effect, but still with persistent disease. And those are patients that if they are BRAF non-mutant, will continue with nivolumab for the balance of the year. And if they are BRAF mutant, we would consider dabrafenib, trametinib for them.
I have a question.
Yes, Charlotte, go for it.
Okay, so there's another question in here. Amongst the surgical audience, we showed you very low resectable disease. But what if somebody had well, first of all, the surgery for that versus the patient who had 4 nodes resectable, 4 or 5 nodes resectable, are we, or at your institutions, are you removing just one node and saying that's a barometer of everything, or are we doing a therapeutic lymph node dissection? Understanding that the NADINA and SWOG trials both required a complete lymph node dissection. It's only the Prado trial that looked at a personalized, right?
Right,
Yeah.
yeah.
So
yeah.
what's your practice? I
So,
can tell you mine,
if
but
there are 4
yeah,
macroscopic nodes,
Yeah.
our plan typically will be a therapeutic dissection.
Yeah.
On the other hand, if you see a dominant node and a few other smaller ones with maybe mild FTG avidity,
Yeah.
we are discussing a Prado-style approach
Yeah.
with savvy clip placement into the dominant node, pursuing neoadjuvant therapy, resecting just the index node. I will admit to this audience that that is not potentially yet standard of care.
Yeah.
I think we need more data on that first
Yeah.
before we can truly validate that approach, and I think those trials are currently ongoing.
Yeah. Charlotte, did you want to speak to Prado?
Yeah, well, sure. So Prado,
Prado, not Prada.
Not Prada.
all right, so, but the important point from the surgical standpoint is if you're going to do this, what was done in that trial was that you put a marker on the lymph node, then the patient gets neoadjuvant treatment, then you resect that index node. If that index node has a complete response, no further surgical treatment is needed. If that index node did not have a complete pathological response, then those patients go on to have a second surgery, which is a therapeutic lymph node dissection. Now, whether that practically happens with everyone, I'm not sure. But that was the trial for de-escalation of surgery. So there was a question here, a complete node dissection versus not. I am with you. If somebody has multiple bulky nodes to begin with, I will still talk to them about this, but I more favor a full lymph node dissection. If someone has one node, the other point is that everyone talks about that imaging does not correlate, but the ends of imaging correlate.
Yeah.
If you have a lesion that's getting smaller, a big node that's 5 centimeters and it's down to 2 centimeters, that patient's having a response. Right. And so we're quite comfortable just taking out that node and confirming that. As opposed to doing a full lymph node dissection, right? Where imaging is terrible is the stable disease node. It's a flip of a coin of what's really going on with that node.
Yeah,
Yep.
yeah, and same, we kind of lean towards the therapeutic lymph node dissection unless there's contraindications, so older individual, a lot of comorbidities, or single node, really good
Right.
response.
Those are the best people, I think.
Yeah.
Single node responding on imaging, that's a very safe people. But we discuss it with the patients that this is not standard of care at this
Right,
point.
exactly. I had a patient come in and ask me for that the other day, and I was like, well, we're going to do a whole lymph node. She had multiple nodes involved. So how about, let's see, Hudson, candidate for neoadjuvant. This is the one with the stage 3 bulky node. Given his presentation, dual checkpoint blockade, consider anti-PD-1 neoadjuvant for patients with comorbidities, concern over IRAs. And then Audrey, I think close coordination between surgeons and oncologists. FNA is the optimal, and then post-immunotherapy TIL could be an option in that setting. And so now it's your turn. So let's reconsider the case.
Should we do some more questions first? What are we on time?
We're a little tight on time, so we might
Okay.
just have them do this assessment, and
sure.
then we'll do the questions
Okay.
after. So, all right, it's up to you guys. So reconsider Rachel's case. So 38-year-old female, stage 3 melanoma, BRAF wild type, palpable nodes, no distant mets. How would you manage her? Music, please. All right, so neoadjuvant ipi-nivo looking like the flip dose. So far, there's a little competition going on here. Do the flip dose, guys. There you go, okay. So Nadina style. Okay, and then Hudson is our second patient. So this is a 54-year-old male, stage 3 BRAF mutant melanoma, has that single dominant node. What would you do for Hudson? Neoadjuvant Ipi-Nivo, followed by surgery and adjuvant PD-1. Very well played, everyone. Excellent. Okay, so we'll go to our, do we have a final case there, or is it the recap? Is it questions? Here we go. Okay, so
Questions.
now it's the question and answer session, and apologies for getting a little tight on time, but I think
Right.
hopefully.
I think there's a couple, I just want to,
Good.
just looking at the thing here.
Yeah,
One thing to, when we talked about unresectable disease with someone asked about a head and neck in transit, but I do want to point that up to 3 in transit lesions were included in the Nadina
Nadina,
trial.
Mm-hmm.
So there is some data about in transit disease in general, but again, 3 in transits that were resectable. So it's a difference between resectable and unresectable disease. And then there's another question here for you. Does PD-L1 matter for you? And what do you think about mucosal melanoma? I know that's a whole other can of worms, but immune therapy for mucosal melanoma.
So again, I'll answer the mucosal first, is we use combination immunotherapy for those patients, including in the neoadjuvant setting. So for example, a patient with a vulvovaginal melanoma, potentially with a positive node in the groin that we are considering for systemic therapy, we will consider Ipi-Nivo. Or interestingly, at least anecdotally, I've seen some very impressive responses with Nivo-Rela for those patients. I had actually called up Dr. Abaria to ask her, in the 29 patients who were on that trial, how many were mucosal, and the answer was 0.
Yeah.
Not a single, it was allowed, but not a single patient with mucosal was enrolled. I've seen some very impressive sinonasal melanomas respond to Nivo-Rela. So there may be something there, but those patients do require combination immunotherapy. I tend to avoid, if those are neoadjuvant cases, I would avoid the anti-VEGF regimen. So for example, a pembrolizumab axitinib, albeit off-label from that standpoint, deriving from some of the data from the Far East, where they had used toripalimab plus axitinib, which we don't have available here. So because of the VEGF characteristics and the plan for surgery, I would avoid that, at least in the neoadjuvant setting.
yeah. There's a couple questions. One, best neoadjuvant options for immunocompromised patients and patients on steroids.
Great question. I don't think we really know the answer to that. If it's an immunocompromised patient that you are, worried about flare of whatever the immunocompromised condition is, there is safety data. For example, in patients who are immunodeficient, you can actually safely give them anti-PD-1 based therapy. I tend to be a little bit more conservative for those patients, giving them monotherapy rather than combination. It all depends on what that underlying immunocompromise is. In patients with steroids, ideally I would like them to be at prednisone 10 milligrams or less equivalent per day before considering them for immunotherapy. Have we treated patients on higher doses of steroids? Absolutely, if we've had to. But in those patients, if BRAF/MEK is an option, that's what I would prefer.
And then a question from the audience here. How do you manage, let's say, a 45-year-old female with a stage 3 melanoma and systemic lupus?
Surgery plus possibly consideration of adjuvant therapy, again, depending on the activity of the lupus, I would call it from that standpoint.
And then another good question. 35-year-old female with any contraindications for neoadjuvant immunotherapy and a 35-year-old female with a 12-week pregnancy.
I knew there was going to be a pregnancy question at some point.
Yeah.
I'd be really careful with that. I mean, I would not want to go down that pathway. You can use vemurafenib, for example. There is safety data in late stages of pregnancy beyond the first trimester, as long as those are, the younger patients tend to have a higher likelihood of having BRAF mutant disease. But obviously the key there is getting that patient safely to delivery and most importantly, examining the placenta.
But also the immune effects of, they're living with an allograft and you're going to give them immune therapy, right?
Correct.
The fetus loss is a real.
All right. I know we're a little tight on time. Carmine, if you want to give me the thumbs up or thumbs down, we could do a few more questions. Is that okay? For anyone, you feel free. We will not be offended if you need to leave. But we will go through a few more questions.
There is a good question about survival curves plateau for stage 2 patients between 2 to 3 years, which is a very good observation. So do we change our strategy of follow-up at that inflection point? We do. So in other words, if someone's NED after 3 years, we go to once a year imaging.
Okay.
Yeah.
Same.
Yeah,
Did
we
you
do
guys?
pretty much the same.
Yeah, we do the same. And then there's one for Charlotte. For a lesion like that in the axilla with one single large palpable node, do you do level 1, 2, and 3?
So that lesion would get neoadjuvant therapy. And as I said, if it was just a single lesion, it was getting smaller, I would not do a level 1, 2, 3. But if there was multiple nodes,
Yeah.
yes, for
Okay.
sure.
And then for clinical N0 but T3B or T4B, do you look for occult node positive with an ultrasound sonogram first?
So for our high-risk stage 2, stage 2B, 2C patients, we will get an ultrasound all the time.
Charlotte?
We do not, but I do look for, I think this scenario is similar in a patient I just recently had, for example, who had a large subungual melanoma, for example, with the idea knowing that single agent may not be as good, and if we could give them dual agent, neoadjuvant would be better. So for that patient, I did investigate a little bit harder and even did a biopsy of a suspicious node, which ended up being negative. But with this whole idea that in a hard-to-treat melanoma, neoadjuvant would be better. So I think it's shifting.
Yeah.
little.
And then here's a question, Nikhil. Patient with stage 3 or progressed on neoadjuvant ipi-nivo, and you give them BRAF MEK. How long do you wait for a response before you would send them for surgery?
So our bias, again, as I mentioned earlier, for BRAF MEK, if we're using in the neoadjuvant setting, is actually to treat longer, 4 to 6 months. We hope to have that data in the public domain once we analyze our own internal data. But we had published on our retrospective series a while ago, and our median time that we treated those patients was about 5 months. You know, I think 8 to 12 weeks in my mind, while you can see a very rapid kinetic of response, it's still not optimal response at that point.
Yeah.
The key question at the 6-month mark, however, is if you still don't see a pathologic complete response, does that mean that that's primary resistance that's already starting to develop, or you just haven't reached maximal response yet? I don't think we know the answer.
Yeah. And I think maybe one more question. There's one on how do you standardize path versus near path CR, how many fields? And there's actually a white paper that's written on this by Tetzlaff et al., which I can send around and make available.
Actually, Dr. Tetzlaff gave a remarkable talk yesterday at the
Oh, good.
INMC,
Yeah.
explaining exactly that, even for folks like us who see this on a regular, now I don't go to the operating room, but he showed us some really cool slides on what they do, how they do, how many blocks do they look at. It really gave us a good understanding on that perspective. Yeah.
A lot of work.
Yes, for sure. All right. Any questions from the audience live before we call it a night? If not, we got one. Okay.
It's a 72-year-old gentleman, comes with a nodular melanoma, 11 millimeters. Biopsy shows it's a 6.5 with incomplete, the margins are still positive. Clinically node negative. Would you consider giving a neoadjuvant immunotherapy for this patient?
Good question.
Great
That's a
question.
great question. So if I've understood that right, 11 millimeter Breslow depth, but you said 6.5?
I mean,
So it's biopsied and there's residual
Stage
melanoma.
2,
Right.
yeah. Stage 2C.
Would I consider
with
neoadjuvant? That's a tough question. We've done it. Let me put it that way. Is that the absolute right thing to do? I think the jury is up in the air on that. I would still, if that patient is a surgical candidate, I would rather they go to the operating room, identify lymphoscintigraphy, tell us truly whether that's 2 or 3, and then help make decisions in the post-operative setting.
This is the patient I'm dealing right now.
Yeah.
72 years old, morbidly obese, diabetic, located on the lower leg.
Yeah. Yeah.
And
Still
eventually,
residual lesion that's palpable as well?
A lesion
I
you
just
could
said-
see.
You can see it. Okay.
you can see it.
Yeah.
You can see it's like
Yeah.
a grape sitting on the skin.
Yeah.
Then I think, yes,
Yeah.
then I think, yes,
I like
would
neoadjuvant.
consider
Yeah.
immunotherapy
I
for
have
that,
done
yeah.
this exact scenario. I had
Yep.
the same thing with somebody who was in a wheelchair, edematous leg, horrible. And we gave neoadjuvant PD-1, and the patient had a complete response by a miracle.
So it became
So I
definitive
actually
therapy.
never operated on this patient, and we're still
Wow.
following them.
Yeah.
But it's not the standard of care. But there has been a trial looking at this. Dr. Karakoussis at a UPenn gave a single dose PD-1,
Yep.
and along with the other group there, and they gave a single dose of PD-1. Of course, you don't know which patients are stage 2 or stage 3, but then they gave a single dose of PD-1. Some of those patients remained stage 2. Some people went on to be what's called stage 3, obviously because their node was positive. They all went to have a node. So they showed that there was a 30% response rate, if you will. And then the Australians are currently doing this trial for patients like this who have residual disease to take out the primary.
Theirs is a very specific
Yes.
trial where they're actually working in conjunction with the dermatologist
Yeah.
and saying, if you look at a suspicious lesion, biopsy only one part of the lesion,
That's right.
intentionally leave some part of it behind.
That's
Yeah.
right, so that they could do it
So that is
neoadjuvant.
purely a proof of principle study right now.
Exactly,
But
exactly.
anecdotally, in high-risk patients, I think we all probably have some people who we've treated neoadjuvantly.
Yes.
You're not going to lose anything in this patient,
Agreed.
right? It's just a lesion on the leg, and if you give 2 or 3 doses and you see a response, great. If you don't, you still are back to this bad surgery option,
Yes.
but you can do it.
That's right.
You're not going to close a window.
That's
Right.
right,
Yeah.
exactly. Is it time for the Amazon gift cards, I think?
Uh.
So go ahead and scan the QR code to answer the final follow-up polls and to ask the faculty
And
your
you may
questions.
win a gift card.
Yeah, and you may win a gift card. Your phone apparently lights up. Okay, so
You
do
see
we
the green winner message.
Yes.
We need music, guys. Come
Yeah.
on. All right. Can we play one final song back there? I think they ran out of songs.
I think they did.
Okay,
The
so
end.
anyway, you can visit us at peerreview.com/melanoma25. So complete and submit your post-test and evaluation for credit. You can actually download these slides and practice aids. Watch the replay with some popcorn of this event in the next 24 hours and the online activity in the coming weeks. And thank you very much for joining us. We had a lot of fun. Hope you did too. Really great questions, great cases, and we'll see you next year.
Thank you.